Good evening, all.
Yourself.
I am Dr. Malaya Mishra, HOD Emergency Medicine at Yashoda Hospital, Secunderabad. So I welcome you all for today's webinar session. As all of you know, every Friday we bring some interesting and relevant topics in our emergency medicines with our experts to discuss for today's session on the topic ischemic stroke, that is very much relevant to our emergency department. How we should able to recognize, what should be the management in emergency room, and what are the recent advancement. So to discuss further, I would like to invite Dr. Balasubramanyam. He has done his DNB emergency medicine, also completed his IDCCM, currently working in Aayush Hospital, Vijayawada. And something related to this topic is, it is very much relevant, as I said. So we will be discussing a bit on this ischemic stroke latest updates on 2024 and how should able to recognize in a timely manner. What is the management we do in an emergency room? What are the innovatives? And based on the current guidelines and practices as per American Heart Association and American Stroke Associations, recent trials, and what are the evolving practices in day-to-day basis. So over to you, Dr. Balasubramanyam.
Good evening, everyone. Thank you, Dr. Malaya Mishra. Today, as Dr. Malaya Mishra has told, myself Balasubramanyam, working as an emergency consultant in Aayush Hospitals, Vijayawada. The topic today we are going to discuss about is ischemic stroke, recognition, management, and recent advances. So, regarding ischemic stroke, I'd like to go on a case present into ER, similar wise, about how we deal with an ischemic stroke in a year. So, stroke, by definition, stroke means
Just one second, Dr. Balasubramanyam. Your voice is little low. Can you just increase your volume?
Yeah. Sir, is it okay now?
Yeah, now it's better. It's better.
Okay. So, stroke is sudden onset neurological deficit due to focal vascular cause or vascular obstruction leading to decrease in perfusion to brain tissue, thereby causing focal neurological deficits. So, injury related to loss of oxygen and glucose substances necessary for high energy phosphate production and presence of mediators, thus causing secondary cellular injury to the brain. So, in any of the brain circulation will be divided into two parts: the anterior circulation, posterior circulation. Anterior involving the internal carotid artery, anterior cerebral, middle cerebral, and communicating arteries. Posterior circulation involving vertebral, bilateral vertebral arteries, basilar artery, and the superior and inferior cerebellar arteries, Fontaine arteries. Anywhere in the circulation, if there is an obstruction, either due to thrombi or emboli, leading to decreased blood supply to brain tissue, thus causing tissue destruction, neuronal cell loss, causing focal deficit. So, thereby, ischemic stroke is divided into three types of strokes based on the causating factor: thrombosis, embolic stroke, and hypoperfusion. In thrombotic stroke, there will be narrowing of lumen over time due to some in situ vascular clot formation process, either by atherosclerosis, polycythemia, dissection, or hypercoagulable state. So these kind of thrombotic strokes usually present gradually. The patient complained that symptoms started gradually, but the inciting or starting point will be sudden onset. Embolic strokes, usually the vessel causing or vessel involved in the process will be normal, but there will be an obstruction to the normal vasculature due to somewhere remote particulate or material causing that obstruction, like cardioembolic stroke, the clot or any embolic material from LV or particulate materials from IV drug users or fat emboli in case of any fractures can cause that sudden obstruction to the normal vasculature, causing embolic stroke. Like previously I said, the valvular vegetations, mural thrombi, fat emboli, or particulate emboli, septic emboli can cause these. In these kind of presentations, the stroke presentation will be sudden onset. And next type of ischemic stroke will be hypoperfusion stroke, which we usually see in cases like patients presenting with hypotension, like septic shock, cardiogenic shock. Patients will be having focal neurological deficit. If we do any imaging, there will be strokes or multiple infarcts in the watershed zone. This will be due to cardiac failure resulting in hypotension. So that is classification of ischemic strokes. And next entity relating to ischemic stroke is transient ischemic attack. It is similar to unstable angina of STEMI or any anginal variants. We can call it, or we can consider it as unstable variant, unstable anginal equivalent. So transient ischemic attack is defined as blood flow to the brain tissue will be limited, or focal neurological deficits which will be limited or resolved within hours, most likely within 24 hours, without any evidence of cerebral tissue damage or cerebral tissue infarction. So all the neurological signs and symptoms of stroke will resolve within 24 hours without evidence of infarction. This is further defined as tissue-based definition of TIA and time-based definition of TIA. Tissue-based definition, there usually won't be any evidence of tissue like infarction and imaging, and the symptoms will resolve within 24 hours. If there is evidence of infarction, we won't call it TIA. And time-based definition is that within stipulated time, like in 24 hours, usually less than 1 to 2 hours, the neurological deficits or symptoms of stroke will resolve, not extending 24 hours. It is a time-based definition. But recently, in many stroke patients with resolving signs and symptoms of stroke, without any imaging or without doing any imaging, we won't consider it as TIA, because considering the time-based definition, there is a lapse, or we are unable to diagnose around 33% of stroke cases, and we are labeling them as TIA. So time-based definition is not as such defined a definition, acute definition for TIA. So like previously I told, anterior circulation and posterior circulation for cerebral perfusion includes anterior ophthalmic, anterior cerebral, middle cerebral arteries, intercommunicating arteries, anterior choroidal arteries. In ophthalmic, based on the origin of the stroke, like vascular origin, it will produce defined focal neurological deficits in specified regions. If the ophthalmic artery is involved, optic nerve or retina will be involved and show deficits like vision loss, blurring of vision, or diplopia. Anterior cerebral artery usually involves frontal pole of brain, a bilateral based on side, and anteromedial cortex, anterior corpus callosum. Middle cerebral artery, frontoparietal lobe and anterotemporal lobe. Middle cerebral artery will be supplying the largest chunk, and most of the times middle cerebral artery will be involved in anterior circulation strokes. Posterior circulation stroke involves vertebral arteries, bilateral vertebral arteries combining to form basilar artery, and then both of them giving branches like superior cerebellar artery, anterior inferior cerebellar artery, posterior inferior cerebellar artery, pontine arteries, and posterior communicating arteries. So based on the vascular involvement, defined focal deficits will be seen. Vertebral artery, if it is involved, brainstem will be brainstem lesions will be seen. Posterior inferior cerebellar artery, if it is involved, otherwise called PICA. Posterior inferior cerebellar artery, if it is involved, cerebellum infarction will be seen, either right or left. Basilar artery involvement is seen in thalamus. Sometimes basilar artery involvement can cause artery of Percheron infarct, which is a significant infarction, even though if it is in posterior circulation. Medial temporal artery causes visual occipital cortex involvement, causing visual impairment. This is the label diagram showing circulation to the brain as well as circular Willis. Circular Willis, which is showing communication between anterior and posterior circulation. Anterior circulation shows internal carotid artery, giving branches to anterior cerebral, middle cerebral, then anterior communicating arteries, anterior choroidal, and posterior circulation showing bilateral vertebral arteries, giving branches to posterior inferior cerebellar artery. Vertebral arteries combining to form basilar artery, thereby giving branches to pontine arteries, basilar artery as such, and posterior communicating artery, and superior, anterior, inferior cerebellar arteries. Symptoms of stroke. Whenever patient comes to ER, a patient may complain of various symptoms ranging from traditional symptoms and non-traditional symptoms. Traditional symptoms include patient having upper limb, lower limb weakness, numbness, tingling or numbness, aphasia, dysarthria, vision disturbance, blurring of vision or diplopia, facial deviation, followed by these complaints are seen usually in anterior circulation. Posterior circulation symptoms usually range from gait abnormality, ataxia, incoordination, slurring of speech, hypotonia, generalized weakness, and generalized weakness or sense of not being well. These can be complaints of posterior circulation, and sometimes patient can present with altered sensorium or loss of consciousness, syncope. This can be presentation of posterior circulation as well. So non-traditional symptoms include impaired consciousness, syncope, altered sensorium, dysphagia, hiccups, nausea, vomiting, recurrent falls, generalized weakness, and very rarely shortness of breath and palpitations. So if the patient comes to here with above mentioned symptoms, first we'll try to rule out hypoglycemia. If the hypoglycemia is ruled out, we'll try to assess the patient whether patient is having complained deficits, signs, and then we'll try to confirm whether the patient is in window period or not. So based on how to assess the patient within window period, initially we used to go for Cincinnati scoring, which used to have components like fast, facial droop or asymmetry, arm weakness, numbness, speech, slurred speech or difficulty speech, time, T for time, which mentions that patient is in window period less than 4.5 hours. But recently, BFAST tool has been proposed by the AHA guidelines, which includes BE as initial fast tool shows only or covers only anterior circulation, and in BFAST, B for balance, sudden loss of coordination, ataxia or gait abnormality, and E for eyes, sudden vision loss or double vision were included, which is important because it includes posterior circulation, and as we discussed in the earlier arteries, ophthalmic artery can cause vision loss or diplopia or double vision. So this includes both anterior and posterior circulations, which is then this BFAST tool is a simplified tool to initially assess whether the patient is having stroke within window period or not. Next comes another tool called fast ED tool, which is used to assess the severity and initially assess whether whether the patient is having any severe stroke or any large vessel occlusion or small vessel occlusion, which this fast ED tool is also similar to the previous BFAST tool, which contains the same components: facial palsy, F for facial palsy, A for arm weakness, S for speech changes, slurred speech, or aphasia also, time for within window period, time of onset, and E for eye deviation, gaze preference or deviation for any ocular involvement, and the D for denial or neglect, whether the patient is conscious and is denying that he is having any symptoms or deficits. This scoring system usually has 0 to 9 score, and 0 to 3 usually signifies that patient is having small vessel occlusions, and if it is 4 or more, it is possible large vessel occlusion, and we can plan for early thrombectomy. This is the one of the benefit for fast ED tool. These are the components. Comparison between BFAST and fast ED. BFAST is used for screening stroke, and fast ED is used to assess severity and whether the patient is having large vessel occlusion. Based on that, we can either take steps. We can act fast for the imaging as the patient will be in window period, or if the patient has possible large vessel occlusion, we can plan for thrombectomy. We can involve a neurosurgical team or interventional radiology team. These, after assessing the screening tools, we'll send the patient to imaging, whether it is CT or MRI, to see whether the patient is having stroke or not. Usually in our hospital, we are following MRI based protocol. So we'll shift the patient to MRI as soon as we assess the BFAST screening. After sending to MRI, we'll try to maintain time period from that the patient from arriving into ER and shifting to radiology less than 20 minutes as AHA guidelines. So after shifting to MRI, within diffusion, we will try to see if the patient is having any hyperintensity, like shown in this image. This image shows anterior cerebral artery infarct in the territory, infarct in anterior cerebral artery territory. And this image showing infarct in posterior cerebral artery territory. And this, as usual, shows infarct in middle cerebral artery territory, which shows both diffusion and flare. And this shows that patient is in window period, as diffusion shows hyperintensity and flare is not having any hyperintensity. So this image shows that in MCA territory, whether right or left, patient is having diffusion flare mismatch. So patient, if any patient is having diffusion flare mismatch, we have to consider that patient is in window period and the patient is a candidate for thrombolysis, and then we have to check for thrombolysis checklist. After imaging, we'll shift the patient from radiology to ER again. So whenever the patient comes, like I said, we'll rule out hypoglycemia. We'll check for fast scoring system to assess whether patient is having stroke. Then we'll try to initially do primary survey. If the patient is having any needs any intervention in primary survey, if he is unconscious, low GCS also, he needs any airway intervention, or having hypoxia, needs supplemental oxygen. So we'll intervene there, correct the primary survey, and then send the patient to radiology for imaging within 20 minutes. Then the patient from imaging or radiology suite will come back to emergency, should be shifted back to emergency. After coming back to emergency, we have to again do a primary survey and then meanwhile confirm the radiology report, whether the patient is having ischemic stroke. So if the radiology report shows that patient is having ischemic stroke, we will continue with the secondary survey after again patient comes to emergency room. Now the primary survey aims at preventing secondary insults to the brain apart from the primary insult, which is stroke. So the secondary insults to the brain will be, again, like the previously said, maintaining the airway, and in breathing we'll try to correct hypoxia. If there is any hypercarbia, we'll try to correct it. And in circulation, if the patient is hypotensive, we'll try to resuscitate him with IV fluids or any vasopressors, preventing hypotension worsening. Like we said, hypoperfusion stroke. By correcting or resuscitating hypoperfusion, we'll see whether the patient is improving. If after correcting that, second thing in circulation is try to avoid hypertension. If the patient is a candidate for thrombolysis above systolic 185 and diastolic more than 110. So we'll try to correct in circulation. And next, coming to disability, we'll try to, as we ruled out hypoglycemia, we'll check whether the patient is having hyperglycemia. We have to correct, we have to maintain normal glycemic levels in this patient in a range of 140 to 180 milligram per deciliter. Correct even hyperglycemia if it is noted.
I think,
And after disability,
Dr. Bala, I think your slide is not moving. The slide is not moving.
I didn't. So, like mentioned, in exposure also, we'll environment and exposure, we'll see the temperature. We'll correct the temperature if the patient is hypothermic or hyperthermic. We'll prevent hypothermia and hyperthermia and try to maintain normothermia. So the management will be, after the patient comes to ER, we'll do emergency survey, emergency assessment, like BFAST tool. And then if the patient is having stroke, we'll immediately alert the stroke team, which includes emergency department, neurology, radiology, and intensivist. If suspicion of large vessel occlusion or severity of stroke, we'll plan for alerting interventional radiology. And after alerting the stroke team, we'll move the patient to the radiology, CT or MRI scan. After the MRI scan, patient comes back to emergency. We'll go for intermediate interventions, which include taking blood samples. If there is a need for Ryle's insertion or Foley's, we'll go for it. And then if the stroke team comes and confirmation of stroke is noted, ischemic stroke, we'll go on with NIHSS assessment, thrombolysis checklist clearance. And then if all is cleared, we'll plan for IV thrombolysis with recombinant tissue plasminogen activator. And we'll explain the patient's family attendants about this, and we'll take the consent, explain the complications in IV thrombolysis. And after taking consent, we'll plan for IV thrombolysis the patient. According to AHA, door to needle time should be less than 60 minutes. We'll try to maintain that, and trying to give IV recombinant tissue plasminogen activator to patient of an ischemic stroke within window period in less than 60 minutes of arrival to ER. So this again reiterates the same. In according to AHA guidelines, door to needle time should be less than 60 minutes. NIHSS scoring is 11-point assessment of score, with score points of 0 to 42, which again has like 0 is no stroke, 21 to 42 is severe stroke. In middle, 1 to 4 is minor stroke, 5 to 15 is moderate stroke, and 16 to 20 is moderate to severe stroke. Usually in minor stroke, we will not thrombolyze the patient. 5 to 24, we'll go for thrombolysis. Again, after 24, there is a risk for worsening of the symptoms in symptomatic intracranial hemorrhage. So we'll defer thrombolysis. In even minor stroke, that is NIHSS score less than 1 to 4, there are some conditions where we can thrombolyze the patient, including vision loss, language or aphasia. We can go for thrombolysis. So like what I told previously, after the patient comes back to emergency room, we'll again do the primary survey and stabilize the patient, along with planning for IV thrombolysis and the thrombolysis checklist and NIHSS scoring. Thrombolysis. Thrombolysis, IV thrombolysis is usually done with recombinant tissue plasminogen activator. Previously, we used to do with altiplase. Altiplase dosage is like 0.9 mg per kg. Maximum dosage is 90 mg. It is given like 10% of initial dose is bolus, and remaining 90% will be given in 1 hour. Now we have shifted from altiplase to tenecteplase, which is more synthetic compound tissue plasminogen activator, which has more affinity to fibrinogen products than altiplase. So there is no as such comparative study which shows tenecteplase is superior or inferior to altiplase, but in ease of working, nowadays we prefer tenecteplase, but tenecteplase is still not approved drug, FDA approved drug for ischemic stroke. So in thrombolysis, we go for, like I said, we'll go for thrombolysis checklist, which includes inclusion criteria and exclusion criteria. In inclusion criteria, confirmed ischemic stroke with symptoms of disability, and treatment can start, or the symptom onset is within 4.5 hours of symptom onset. Previously it was 3, and later on the 1.5 hour was included to 4.5 hours. And age should be more than 18 years. In some cases, wake-up stroke will include in thrombolysis patient with ischemic stroke who are having diffusion flare mismatch. Within we consider it as within window period or less than 4.5 hours of stroke. And exclusion criteria. In exclusion criteria, if it is an ischemic stroke out of window period, that is more than 4.5 hours, any history of intracranial hemorrhage, subarachnoid hemorrhage, intracranial neoplasm, space occupying lesions, ischemic stroke or head trauma within 3 months, brain surgeries within 3 months, GA bleeding or malignancy within last 3 weeks, or any puncture, non-compressible puncture site within the last 3 weeks, thrombocytopenia or INR greater than 1.7, CKD with creatinine, elevated creatinines, BP with more than 185/110 systolic and diastolic despite treatment, and any person who is on anticoagulations using low molecular heparin or Novax anticoagulants within the last 48 hours, we tend to exclude them from IV thrombolysis. Similarly, arterial puncture site, which is non-compressible, AV malformations, systemic malignancies, major surgery or trauma within the last 2 weeks or 3 weeks, and in menstruation. Menstruation as such is not a contraindication, but menstruation with significant anemia warrants an evaluation. It is a relative contraindication, and first we need to identify anemia. We have to give reference to gastroenterologist, we have to take opinion, and then we have to plan for thrombolysis if it permits. And for thrombolysis, there are 2 landmark trials which proposed thrombolysis in ischemic stroke patients. They are like, first one is NIHSSS trial in 1995, which proposed tissue plasminogen activator for ischemic stroke. Comparing with placebo and tissue plasminogen activator, there is an increased incidence of symptomatic intracerebral hemorrhage with tissue plasminogen activator within 3 hours, but there is improved clinical outcome in terms of improved neurological deficits or symptoms at 3 months of duration. So NIHSSS trial suggested that we can go with tissue plasminogen activator in acute ischemic strokes within 3 hours. From 3 hours, it has been extended to 4.5 hours by ECAS 3 trial in 2008, which demonstrated RTPA, recombinant tissue plasminogen actuator beyond 3 hours up to 4.5 hours resulted in improvement in neurological outcomes. It resulted in 20% increase of RTPA utilization in stroke patients. Other trials which show thrombolysis, benefit of thrombolysis in acute ischemic strokes are diffuse 1 and 2, which showed suggested that either in wake-up strokes or normal perfusion or diffusion flare mismatch. In cases of diffusion flare mismatch, thrombolysis can be used and it shows improved outcomes. Mr. Witness trial in 2015. It is also MRI basic selection showing diffusion flare mismatch in case of wake-up strokes. Similarly, extent trial, which is completed recently, showed recombinant tissue plasminogen activator usage up to 9 hours in wake-up strokes showed functional benefit, but it is still not fully accepted or fully used in literature now. Enchanted trial in 2016 showed compared between low dose and standard dose of 0.6 to 0.9 mg per kg of altiplase. In low dose altiplase, it showed that there is no superior benefit of improvement in neurological outcomes, but it showed decrease in incidence of symptomatic intracranial hemorrhage. But it is still not as such advised to follow low dose RTPA usage because it didn't show any superiority in neurological outcomes compared to normal dose. It showed higher disability, so it is not used. After thrombolysis and during thrombolysis, after planning thrombolysis and going for thrombolysis, we have to monitor the patient throughout thrombolysis and after thrombolysis. So monitoring will be like initially every 15 minutes for the first 2 hours and every 30 minutes for the next 6 hours and hourly for next 16 hours, total 24 hours, one day, we have to monitor the patient. What are we for monitoring for? We have to monitor the patient whether there is improvement in neurological status, worsening of neurological status, or the neurological status remains the same, and complications relating to RTPA, including allergy or anaphylaxis, angioedema, bleeding manifestations. It can be minor bleeding manifestations like gum, skin, mucocutaneous bleeding, or bleeding into brain like symptomatic intracranial hemorrhage, which is life-threatening, and any other bleedings. So we have to monitor for these, like I mentioned previously, and if we notice any angioedema, anaphylaxis, or bleeding manifestations, we have to alert the neurology team. We have to stop thrombolysis. We have to, in case of allergy or so, whether we can plan after initial symptomatic treatment also, we have to discuss with neurology team, but it is advised to stop thrombolysis. In angioedema, like previously discussed in like what we discussed in anaphylaxis, we can stop thrombolysis. We have to stop thrombolysis. And next we can go for either icatibant or cryoprecipitate transfusions also. Symptomatic intracranial hemorrhage, we have to stop thrombolysis. In case of tenecteplase also, which is an IV bolus dose. So if patient is worsening in neurological outcome, in neurological terms, deficit is worsening, we have to consider primary survey, stabilizing, and consider immediate CT brain. If CT brain shows symptomatic intracranial hemorrhage, we have to plan for, if it is life-threatening, yes, it is life-threatening complication. We have to plan for EDTA and FFP transfusion or PCC, prothrombin complex concentrates. And by that, if it is debilitating, we have to plan for, after transfusions, decompressive surgeries. Complications, as I mentioned previously, anaphylaxis, angioedema, allergy, non-resolution of symptoms or worsening of symptoms, symptomatic intracranial hemorrhage. Apart from these complications, the routine complications of stroke can also be noted, which include progression of stroke, cerebral edema, hemorrhagic transformations. Initially, we have to consider intracranial hemorrhage. After some days or week, we have to up to a week, we have to think of hemorrhagic transformation. Cerebral edema is a lethal complication in stroke. Progression of stroke or cerebral edema, these are complications. Cerebral edema is a lethal complication. Next treatment modality apart from IV thrombolysis is endovascular therapy. Like we have seen previously, the IV thrombolysis modality has been started in 1995 and has gained popularity and treatment in emergency mostly after 2008. And endovascular therapy, the new modality, has come to limelight after maybe in the last decade. After 2015, there are many trials, studies showing benefit of endovascular therapy. So that's why in initial screening tools, it is proposed that fast ED tool is one of the tool in screening where we can assess whether the patient might be having large vessel occlusion and early planning for endovascular therapy. Endovascular therapy includes intra-arterial thrombolysis and mechanical clot disruption or extraction. Potential advantages of these endovascular therapy is non-time based, as in like for IV thrombolysis 4.5 hours. Time period for endovascular therapy can extend up to 24 hours, 16 to 24 hours. And in patients who are contraindicated to IV thrombolysis, we can plan for endovascular therapy. Ability, and this is an ability to specifically use in occluded vascular territory and use of lower doses of thrombolytics and possibility of mechanical clot disruption is noted with endovascular therapy, which is not seen in IV thrombolysis. Previously, before 2015, the trials didn't show any benefit of endovascular therapy, but later on, after 2015, there are many trials which show benefit of endovascular therapy, showing improvement in neurological outcomes in terms of mortality and morbidity. Mr. Clean trial in 2015 is used to assess efficacy of mechanical thrombectomy. It showed endovascular therapy is superior to standard care alone. Other studies include Extend IA trial in 2015, which is used to assess whether small infarct core and solvable penumbra identified in CT perfusion scan can benefit from thrombectomy. Outcome was in good notes. Escape trial in 2015 was used to determine whether benefit of thrombectomy within 12 hours based on imaging criteria. It used aspect score and multiphase CTA, digital subtraction angiography, to see whether solvable tissue is there and mechanical endovascular therapy can benefit outcomes. It demonstrated better outcomes with fast workflow and patient selection. Swift Prime study in 2015 is used to determine whether endovascular therapy added to IV thrombolysis improves outcome in patients with large vessel occlusions. Outcomes show significant benefit in terms of neurological outcomes, functional independence. And ReverseCAT in 2015 is used to assess whether thrombectomy patients within 8 hours show benefit. Outcomes showed that improved outcomes were noted with thrombectomy within 8 hours. In Diffuse 3, as ReverseCAT has shown within 8 hours, next studies will show extending the time period, which are Diffuse 3 and Dawn trials. Diffuse 3 showed improved outcomes with endovascular thrombectomy within 6 to 16 hours of onset of symptoms. And the Dawn trial showed thrombectomy has shown improved in neurological outcomes in 6 to 24 hours of stroke onset. stroke retrieval thrombectomy, according to NIHSS guidelines, stent retrieval thrombectomy, I'm sorry, stent retrieval thrombectomy, there are 7 criteria which should be fulfilled, which include confirmation of stroke, age greater than 18 years, NIHSS score greater than 6, aspect score greater than 6, blockage of large vessels like internal carotid artery or immense segment of MCA, and patient has received IV thrombolysis therapy within 4.5 hours, groin puncture within 6 hours, and modified ranking score of 1 and 2, 0 and 1, sorry, 0 and 1, with minimal disability or no stroke symptoms. So these are recent updates or recent trials which showed that endovascular therapy showed better outcomes, improved in functional outcomes, neurological outcomes in ischemic stroke patients by use of endovascular thrombectomy. As I stated previously, cerebral edema in case of stroke patients, ischemic stroke patients, is one of the lethal complications. If ischemic stroke, in ischemic stroke, if cerebral edema is noted and patient is having a worsening of focal neurological signs or sensorium, we have to plan for decompressive craniotomy. Decompressive craniotomy is the treatment in case of massive MCA infarct, which is having cerebral edema with worsening of neurological signs. So initially it was trial was done in 2014 which showed no clear survival benefit, but later on other trials like Decimal, Destiny and Hamlet showed improved survival outcomes compared to medical therapy alone. Next entity in ischemic stroke is what we discussed earlier, transient ischemic attack. Transient ischemic attack is defined as transient episode of neurological dysfunction caused by focal brain, spinal cord or retinal ischemia without acute evidence of infarction in the brain tissue. So, like I said earlier, we cannot consider all patients who come to emergency who are having improved neurological symptoms within 1 or 2 hours as TIA, because around 33% of patients who present to emergency with resolving signs and symptoms can have image evidence of infarction, which suggests that it is not a TIA and it is a stroke. So we have to go for imaging, confirm there is no image evidence of infarction, and label it as TIA. So next comes the treatment of the workup of TIA is as usual, like what we do in stroke. We assess the patient, and then we'll go for lab investigations, ECG, echocardiogram, and carotid Dopplers, neck vessel Dopplers also to rule out thrombi, embolic cause. After ruling out, we'll go for CBC, RFT, electrolytes also, and the previous history of any headaches, fever, to rule out stroke mimics. After ruling out, we label it as TIA. In TIA, we will go for a treatment like, if there is no atrial fibrillation, ECG is normal, we'll go for dual antiplatelet therapy. Chance trial has shown that aspirin and clopidogrel combined will have 90 days benefit of secondary prevention of TIA and stroke. And in case of atrial fibrillation, in case of TIA with atrial fibrillation, we'll go for anticoagulation, whether it is valvular or non-valvular cause. Anticoagulation has to be prescribed based on Chadwick score. And ruling out with Hasbett score. That is it. Thank you. I hope I am clear to everyone.
Yeah, thank you so much, Dr. Balasubramanyam, for such a elaborative and very interesting discussions on this topic of acute ischemic stroke is concerned. So as you have clearly mentioned about the key updates regarding this acute ischemic stroke diagnosis and management is concerned. So few things I would like to highlight here. One is MRI based DWI flare mismatch. As you have clearly mentioned, it allows IV thrombolytics in patients with unknown time of onset as per workup trials. And second thing is regarding this perfusion imaging integrations, like extended use of CT perfusion images or MRI perfusions to determine the salvageable brain tissues, that is a penumbra. And it will be helpful guiding the thrombectomy beyond 6 hours. Like as per the current guidelines, what you are saying, like up to 24 hours for the selected patients, as per this DAWN trial or diffuse 3 trials, extended time window for mechanical thrombectomy. You have clearly mentioned. And one thing I just wanted to add here, it is dual antiplatelet therapy, DAPT roles, that is like clopidogrel along with aspirin. Recommendations like for 21 to 30 days for minor stroke or TIA, followed by monotherapy. Like either you can switch to clopidogrel or aspirin. And this anticoagulation timing on atrial fibrillations, like cardioembolic stroke. So that is 1, 3, 6, 12 rule. Like for TIA, we should start for 1 day. And for minor infarct, should be started for around 3 to 4 days. For moderate stroke, moderate NIHSS, we need to start for around a week, 6 to 7 days. And for large infarct, should be ideally around 12 to 14 days. And this is based basically on the ELAN trial 2023. That is the early initiation is generally safe and effective. And of course, they are now recommending high intensity of statin uses. Like atorvastatin should be used at the highest level, that is around 80 mg, unless it is contraindicated. Okay. Apart from that, nothing. We have covered everything. The current, whatever the guidelines, it is like use of tenecteplase in place of alteplase in selected patients with large vessel occlusions. That is the current updates. And like stronger emphasis on this imaging based, what I said, CT perfusion or MRI perfusion based selection for treatment. Recommendations for early dual oral anticoagulants initiations for cardioembolic stroke. Support for thrombectomy up to 24 hours in wake-up strokes. These are the recent changes. So is there any questions for the speaker? So I have certain questions for you, Dr. Balasubramanyam. Can you just elaborate us what differentiates anterior from posterior circulation stroke syndromes?
Differentiates from anterior and posterior circulation stroke syndrome.
Yes.
Differentiates in terms of symptoms.
Yeah, symptoms.
And,
Clinical findings.
clinical findings like in anterior, usually there will be symptoms like behavioral changes, frontal involvement, behavioral changes, anterior cerebral artery territory, and middle cerebral artery territory will be more of focal deficits, limb weakness, facial deviations. In terms of cortex, there will be say either single limb, unilateral limb, or single limb. If it comes to medially, in terms of internal capsule, where there will be dense fiber involvement, which shows dense hemiplegias. These are usual findings of anterior circulation strokes, and in posterior circulation, usually symptoms will be of vision disturbance, gait disturbances, vision disturbance, gait disturbances, diplopias, ataxia, and sometimes they can present with loss of consciousness syncopes, like in areas where a stroke of Parcheron infarct, artery of Parcheron infarcts also, they can present as syncopes.
Yeah. Along with that, they will be having some cross signs like facial weakness with contralateral limb signs. That's cross signs. Okay. And one more query is like what the chat box is showing, like what are the key components for NIH stroke scale? So being an emergency physicians, what are the key components the emergency resident should be focused while evaluating a acute ischemic stroke?
In NIHSS stroke scale, the points we have to notice are, if usually in these days we are having a PDF where
PDF or app?
we can make a checklist and see. But if we don't have that or we are in a hurry, we can focus on level of consciousness and the conspicuous signs like facial deviation, asymmetry, limb weakness. Then comes to
The
sensory deficits.
visual fields, the gauge, the
Uh,
visual fields, the
visual
gauge.
fields, gaze, facial asymmetry, limb weakness, ataxia, incoordination, sensory deficits, and then it comes to extent,
Extensions or
inattention,
inattentions.
and these are usually things we can focus on if we don't have a checklist. And other things are vision. Vision, if there is any impairment, hemianopia or vision loss, we can divide eye into 4 quadrants and we can check whether he's having any vision loss. These are usually we can do.
Yeah, basically the language also we need to address.
Each.
The language and dysarthria part, as we have clearly mentioned. So maximum score is 42. That's the highest score, having worse outcome or worse deficit. And so how is a transient ischemic attack different from a minor ischemic stroke?
Minor ischemic stroke usually comes with asymptomatic or minor symptoms where there will be patient can complain of generalized sense of not being well, or sensory deficits, dysarthria, and simple facial deviation, which doesn't affect much of patient's ability to work or so. But there will be imaging evidence that there is an infarct.
Yeah, lacunar infarct. Small lacunar infarct will be there.
In TIA, there won't be a imaging evidence.
So basically the symptoms resolves within first 24 hours and there's no infarct on imaging. It's a TIA, it's a transient period. So it will be resolving on its own. But it's a warning signs of stroke. So all TIA patients should be admitted to the hospital because they have chances they might develop future stroke. So that contributes almost 40 to 50% chances. If TIA persons is not getting admitted, chances are there like that might develop into a complete stroke in next 24 hours.
Yes.
So you have clearly mentioned how is blood pressure managed during the acute ischemic stroke, pre-stroke, and during the stroke, and without thrombolysis?
During stroke, before thrombolysis, if it is more than 185 by 110, we'll tend to use labetalol and decrease blood pressure below 185 by 110 so that we can go for thrombolysis. During and after thrombolysis, if it goes beyond 185 by 110, then we'll go with labetalol, bolus dose, and then infusions. Based on what we have in ER, clavitipin or labetalol. If the first line labetalol doesn't work, then we'll go for sodium nitroprusside infusion to decrease the blood pressures.
Thank you. Thank you so much for this elaborative discussions. And I'm sure it will be helpful for all those who are listening right now, or else it will be a recorded sessions. So people will be benefited by your extensive lectures. And like I sincerely extend my thanks to the Yashoda Hospital management for providing this opportunity to participate in this weekly webinar sessions, which has been truly enlightening for all our emergency medicine residents and physicians who are working. So thank you once again, Dr. Balasubramanyam, for the nice discussions
Thank you,
and
Dr.
extensive
Malaya,
discussion about acute ischemic stroke. Thank you.
Thank you so
so
much,
much.
Dr. Malaya.
Thank you.